So continuing on with the conditions, heart failure is an insufficient heart pump mechanism. So again, as we all know, the importance of the heart being able to beat and circulate blood throughout the entire body. Well, this is a situation where the heart does not do that to a sufficient point to allow that circulation to occur. What I want you to do with heart failure is look at, on table 6-9 in your textbook, there's different types based on location, if acute and chronic. One of the big signs and symptoms related to heart failure is swelling and edema formation. So where the edema forms in heart failure is really based upon which side of the heart, which sided heart failure, whether you're having right side or left sided heart failure, is occurring. Another specific type of heart failure is what's called cor pulmonale. And cor pulmonale is right-sided heart failure caused by a pulmonary disease. So it's related to an actual condition involving the lungs where right-sided heart failure occurs. Myocardial ischemia. So as we talked about earlier in the semester, ischemia is any time you have decreased blood flow to a region causing tissue death. So obviously if there's lack of blood supply to the heart, there's going to be decreased oxygen being delivered to the heart. And the heart, just like any other type of muscle, requires blood supply and oxygen. And we know that the blood supply to the heart is through the coronary arteries. Myocardial ischemia can be caused by a lot of different issues. Again, the one that probably gets highlighted the most is coronary artery disease, whereby the fatty deposits build up in the coronary arteries, therefore blocking the circulation. But it can also be caused by other conditions as well. So it's important to see the link between some of the other conditions we talked about and myocardial ischemia. Arrhythmiogenic right ventricular dysplasia. So this is a fatty infiltration and fibrosis of the myocardium, and in particular the right ventricle. So what happens basically here is fat actually builds up in the muscular wall of the right ventricle. So, and they do believe that one of the causes of this, that there's probably a genetic component related to it, and the issues that could come about because of this are ventricular tachycardia and ventricular arrhythmia. So as we talked about, tachycardia is when the heart starts to beat faster than normal, so a higher heart rate. And arrhythmia is essentially when the rhythm of the heart is abnormal. So those are two of the issues that could come about as a result of this condition. So it's important, again, just as with any of the other conditions, and where you'll normally see this is people that have cardiac signs and symptoms related to heavy exertion or physical activity. Valve disorders involve various types of deformities, either congenital or acquired, of the two valves in the heart. So if you remember going back to looking at the anatomy of the heart, we have the atria and the ventricles. Well, between those two areas, there's valves that regulate the flow of blood going from the atria to the ventricle. On the right side, you have what's called the tricuspid valve. On the right side, you have the bicuspid, or also known as the mitral valve. Again, these types of deformities can be either congenital or acquired. I didn't get a picture on the slide. Figure 615 in your book really has a good illustration of what some of these valves look like. There's also valve deformities that can actually occur in the aorta as well. So they're not just solely limited to just the mitral and tricuspid valve. So stenosis is one of the most common types of deformities, and all that basically is a narrowing of the valve. So the valve becomes more narrow, which obviously can obstruct the blood flow. There's also different types of just basic structural malformations that occur at the valve. Many times that will be very common to hear with these valves are murmurs, which are abnormal heart sounds when you're listening or auscultating the heart. Mitral valve prolapse is probably one of the more common valve disorders, and what basically happens is instead of the valve closing, so when the atria contracts, it pushes blood into the ventricle. Instead of the valve closing, it kind of flips back open and allows the blood to kind of regurgitate back into the atria. That's one of the more common ones. However, it's also many times benign, and your textbook goes through and you're looking at as far as being cleared for activity. Individuals with heart valve disorders can sometimes still participate in activity depending upon what their other, if they have any other alarming signs or symptoms related to them. So next we're going to take a look at some different types of conduction disorders. So if you think about what we had discussed in class in relation to the cardiac conduction system, so we had talked about how the heart has its own kind of electrical circuit that manages the beating and the contraction at the different parts of the heart. And we're going to look at some conditions now that look at disturbances related to that. So one is paroxysmal supraventricular tachycardia, which is a conduction disorder that causes a rapid heart rate at rest. So it basically causes a significant increase in heart rate even when the individual is resting. We obviously know that the heart's going to beat faster when someone's doing some type of intense or high exertion physical activity, and it's the case here where the heart rate is very fast at rest. And usually the issue here is a defect in the discharge at the SA node, atria, and AV node. So we had talked about, and I want you to know where the SA node and the AV node is and what their main responsibilities are. So it's an issue in regards to the discharge and the function related to those areas. Long QT syndrome, again, another conduction disorder. So what this looks at is the QT. So this is in reference to an electrocardiogram. So we had talked about the electrocardiogram and the different parts related to that. Again, that's another thing I want you to know about general cardiac assessment. What happens here is you get a prolonged or abnormal QT interval. Okay, the QT interval is the time it takes for the ventricles to depolarize and then to repolarize. So what you look at is, again, the ventricles getting stimulated to contract and then kind of go through a rest period. And what happens is that time gets longer. So anytime you have something related to the heart contraction getting disturbed with that, it's going to possibly predispose somebody to, in this case, what happens many times is a ventricular tachycardia, where the ventricles actually start to beat faster and faster. So, and I have a picture kind of illustrating what that looks like. You can see the normal QT interval and a prolonged or abnormal QT interval on the bottom. So it's another type of cardiac conduction disorder. Wolff-Parkinson-White syndrome, again, another conduction disorder. And what you have with this is what's called an accessory conduction pathway. So if you look at the picture on the screen, the one side shows a normal electrical pathway of the heart. And you can see how the SA node and AV node interact and how it goes through the other kind of nerve fibers throughout the heart to, again, regulate the heartbeat. That's a normal conduction pattern. Whereas in the second picture, you have what's called an accessory pattern, where the electrical signal doesn't conduct the normal way it would with the regular conduction pathway. And you can actually see on the bottom, they show a normal sinus rhythm with an electrocardiogram and an abnormal one with Wolff-Parkinson-White. The issues, two of the biggest issues or two of the biggest complications that could come with this are atrial fibrillation and ventricular fibrillation. So, and this is going to happen due to, again, issues related to when that electrical signal gets directed to the heart, through the heart rather. So anytime you hear the term fibrillation, it's basically to kind of think about what that would be like when you hear fibrillation with the heart. It's basically like a non-functional quivering. So when you think of the heart contracting and going through that lub-dub, and how the atria contract and the ventricles contract, instead of having that, the muscular wall of the heart kind of just quivers non-functionally. So very important that this gets taken care of. Ventricular fibrillation, particularly because ventricular fibrillation is fatal if an individual is not defibrillated within minutes. So it's very important. An individual with Wolff-Parkinson-White syndrome is aware of this, and we will look at, the textbook will look at the various types of treatments related to this type of condition. Marfan syndrome is a connective tissue disorder, and it's a disorder that doesn't exclusively affect the cardiac system. There are different, obviously there's connective tissue throughout the entire body, so it can affect various regions, but there's particular interest in the cardiovascular system because one of the issues related to Marfan syndrome is a dilation of the aorta. So the aorta is the large artery that leaves the heart coming from to deliver blood to the rest of the body. And with a condition like this, it basically weakens the connective tissue. So the actual aorta in someone with Marfan syndrome, if they're subjected to a lot of physical stress, can actually get damaged and burst open, and that's always the fear with Marfan syndrome. And there are various signs and symptoms, signs rather, that you can see in an individual with Marfan syndrome. Tall, thin body type. They have an arm span longer than their height. You'll see they'll typically have disproportionately long legs. They will have what's called thoracic spine kyphosis, where the thoracic spine is the curve of the thoracic spine is very heavily emphasized in the individual. A lot of times they have sternum deformities. You see in the picture the pectus excavatum, which is when the chest wall is kind of caved in a little bit. There's some clinical tests that an athletic trainer can utilize if they're ever concerned that somebody might have Marfan syndrome. Any type of hyperlaxia in the joints, so if you just look at the fingers, if you kind of extend the fingers and you can kind of hyperextend them back very far, an overlap of the thumb and fifth digit when you wrap them around the wrist. So if you take your fifth digit and your thumb, wrap them around your wrist, they shouldn't overlap. And somebody with Marfan syndrome, they will. Part of what causes that is what's called the arachnodactyly. If you see on the screen, the very long fingers. So somebody with this will show that. So those are some things to kind of look at in maybe screening somebody for Marfan syndrome. Commotio cordis is when there's a very focal hard blow to the chest region during cardiac repolarization. So during a certain part of the heart's contraction cycle, if a very focal, forceful strike to the chest happens, it could actually cause the heart to go into an arrhythmia. It could cause it to go into ventricular arrhythmia. So again, the picture kind of illustrates this and gives some examples of some common projectiles where this could happen. So again, it has to hit it just right at that time, and this does happen. It's a concern in any sport where there's a projectile, and again, the picture gives some examples of how this could happen. But if the person does take a hard blow to the chest during that part of the conduction cycle while the heart's repolarizing, they could go into a ventricular arrhythmia, and they will require an AED within 2 minutes to be able to revive the person. So again, illustrates the importance of being prepared while covering an athletics event and having the appropriate equipment. Getting an AED on this individual, as I said, within 2 minutes is vital in saving them. Hypertension. So hypertension is high blood pressure, and usually the way this gets diagnosed is when an individual has a resting blood pressure over 140/90, so 140 systolic, 90 diastolic, on 2 or more occasions is going to be diagnosed with hypertension. Optimal blood pressure, so I have here, what's optimal blood pressure? Optimal blood pressure, we always say 120/80. Technically, optimal blood pressure is just below 120/80. 120/80 is actually considered pre-hypertension. So what you actually would like to see is a blood pressure, a resting blood pressure below 120/80. So for instance, like 115/75 would be even more optimal for blood pressure. Your textbook goes through some of the different stages of hypertension and pre-hypertension. The difference between primary versus secondary hypertension. Primary hypertension is hypertension without a known cause. So the person has high blood pressure, but we don't really know why they have high blood pressure. They just have high blood pressure. Whereas secondary hypertension is caused by a known disease or known condition. So for instance, a person who has kidney disease could have secondary hypertension. So that's the difference between the two. Obviously, when we look at long-term consequences, hypertension, regardless whether primary or secondary, needs to be treated due to long-term complications. So, heart disease, stroke, damage to the blood vessels in the eye, damage to the blood vessels in the kidney, hypertrophy of the left ventricle. All of this can be caused by hypertension if not treated appropriately.